Well, thanks everyone for coming out to our research roundtable on social behavioral sciences at USC. So this is a kind of a joint venture between the Institute for Addiction Science, the Keck School of Medicine COVID-19 Research Task Force that you'll hear a little bit more in a minute. Yeah, so we're excited. Well, why don't we start with introductions, at least of myself, Jennifer, and Kristen, who put this together. So. Great. And so, like I said, I'm Adam Leventhal, Director of the Institute for Addiction Science, Professor of Preventive Medicine and Psychology, clinical psychologist, and public health scientist, and really kind of interested in the broad spectrum of work that we'll be talking about today. Jennifer?
Hi, I'm Jennifer Unger. I'm also a professor in preventive medicine and have been attending the meetings of the Keck COVID task force led by Michelle Kipke. I'm involved in a lot of different behavioral health studies, and I'm interested in finding out how we can incorporate COVID research into them.
And my name is Kristen, and I may have already emailed with you. Nice to meet you. I'm the Director of Operations of the Institute for Addiction Science, and I've been working alongside Adam for the last year in the Institute, and looking forward to telling you a little bit about it later, and thank you again for joining.
Yeah. Well, so let me just kind of, the big picture, like what are we doing here? So I think there's a lot of ways in which social and behavioral science intersect with COVID, right? So we're interested in social, economic, behavioral, anthropological, societal factors, that can actually increase people's risk of developing the disease. What's it like if you do have the disease, and what are the psychosocial, economic, and so on and so forth, the effects of actually having the disease, or maybe you're a caregiver, or maybe you are a family member of someone who has the disease. And then, of course, as many of us are thinking more broadly, just kind of the world is different now, right? And so what, all the kind of the fallout from this pandemic, how is it going to affect all of our social systems and kind of the way we think, behave, and interact is key. So what we decided to do is put this, webinar together, where really the goal is just to bring some folks who are doing some research, or at least are very interested in doing some research, let them talk about what they're doing so that we can create more links and collaboration. So that's kind of the key thing here. So if you're someone listening or watching, we hope that you either learn a way in which to do research in the new normal, where we can't do what we've done before, right? In a lot of the ways we do research. Two, you see someone or something that you're interested in that pursues you to do a new research study. Or three, you have an idea in mind and you see one of the presenters or perhaps one of the other people who are signed up for this meeting as a potential person you want to collaborate with. So, so with that, we'll be talking a little bit about how this came about. This is kind of we'll talk a little bit about how Keck has this research task force, and there's a behavioral and social sciences and mental health focus in the types of resources that are available through Keck School of Medicine, but also, the resources across the university and kind of how those can synergize. And, the Keck School of Medicine is very interested in forging new collaborations with social behavioral sciences to complement the biomedical and clinical research. So we'll talk about some resources, some that you know about, some that you don't, including funding. Then we are really blessed to have our esteemed presenters who are going to do a quick overview of the work that they're doing. So listen intently. There will not be questions during the process. We're going to do this like panel symposium style. So listen, watch, take notes. And then at the end, we're going to do a roundtable where you can ask questions. And we hope and assume that many of the questions that you're going to have may be relevant to many of the presenters here. Next slide. So just a little bit, this is our research task force. So the Keck School of Medicine is uniquely impacted by the pandemic because, of course, it's a healthcare delivery institution in addition to a research and educational institution. So what we wanted to let you know is just there are a number of different types of affinity groups and processes going on for people who are doing, preclinical research, clinical trials, epidemiology, population-based research, our social behavioral and mental health research, and community engagement and outreach, which Kayla, who's one of our speakers, is co-leading that. And so, the reason why this is important is also there is likely to be a couple of resources, including funding opportunities coming out of Keck, where there's a lot of interest in forging collaborations between Keck researchers and researchers across the university. Next slide. So these are some of the things that the School of Medicine is working on. There's a biosafety laboratory, a new biorepository with tissue samples and other types of samples that can be linked to social behavioral variables that folks might be interested in. Of course, clinical trials going on, both therapeutic and also potentially for caregivers and other people psychosocially affected. There's a Keck healthcare worker surveillance cohort that's going to be happening that Jennifer is co-leading, that Jennifer can talk about. A patient cohort that's in development too, where there's a lot of interest in leveraging this patient cohort who has the disease and kind of following them to not only kind of understand diagnosis, treatment, and clinical outcomes, but also we're hoping that we can infuse some social behavioral perspectives on with this cohort. So this is in development. And then also a research fund. So there is an RFA that is in development. Hopefully it'll be released next week with funds to complement other funding sources in which we, I'll tell you about in a second. But stay tuned and we will follow up with all the attendees with once the RFA comes out with information about that RFA and more information about these kind of Keck specific resources. Next slide. Jennifer, can you talk about the healthcare worker study?
Sure. So Keck is planning to do a cohort study of healthcare workers at Keck, including those who are on the front lines treating COVID patients, those who are not treating COVID patients, those who are in different roles because of COVID. All the different healthcare workers are having all different experiences. So the basic idea is to enroll them in a prospective study with a very low burden enrollment process where they do electronic consent and do a very brief survey during COVID while they're busy and stressed out, and then follow them probably with mobile technology, maybe once a week or maybe once a day if they'll let us do that, to look at changes in symptoms, integrate any testing results that they have into their data, and then later we hope to do some longer psychosocial surveys to look at the mental health impact of COVID on them. And we're still in the process of getting approval for this. We approached the medical directors and they're very wary because they don't want a bunch of researchers like bothering their healthcare workers when they're busy. So we're trying to make this as seamless as possible and as low burden as possible. So we're still negotiating, what would be doable with the health system, but we hope that we get this into place soon.
Thanks. Next slide. Oh, so here's so how many people are attending, Kristen? You said it was like a lot.
Well, it looks like right now we have 121 people in the room. We had about 160 registered.
Wow.
So
okay,
nice.
So yeah, special thanks to all of you out there. And I guess it speaks to how much motivation people have to use science to address this, because we're all kind of distressed about what's going on. So what's cool about here is look how interdisciplinary. So you can see that how many schools? 8 schools maybe are represented. In terms of the faculty attending, we have staff people attending who are really interested, students and community members, and then also some of the healthcare providers too at our local Keck and USC affiliated hospitals. So this is really exciting. Next slide. Just a little shameless plug for our institute. We, this is really in our wheelhouse. The Institute for Addiction Science is really interested in forging collaborations and providing infrastructure to facilitate transdisciplinary research and education on addiction. We do have a new interdisciplinary addiction science minor that's going to be launched this fall. Maybe in person, maybe not in person. That's a partnership with the School of Pharmacy, Dornsife, and School of Social Work. So we've been doing this in terms of addiction for a couple of years now. And so we're really just excited to take this transdisciplinary approach and apply it more broadly to the pandemic and social behavioral sciences, not just addiction. Next slide. So thank you, Kristen, for putting this together. This is just a small snippet of the various research topics that folks were said that they were interested in pursuing. So are there a couple of themes, and this is not all of them, but as you can see, food insecurity, of course, substance use, aging. We have people from the Davis School on, which is great too. And then many kind of other aspects, and I think, and some other interesting topics too, including use of robotics and other kind of data science, or really kind of modern mobile technology intersection with health. So a lot of cool things, and we plan to send you all a table with all the names of the attendees, and then those who listed a research topic or research study that they're interested in, those will be on there. So feel free, everybody, to scour those and email folks that you are doing topics and things that you think are interested in. I can't guarantee that they'll respond, but they probably will. And then, of course, Kristen and I and Jennifer can help also forge connections too, if there's someone that you're trying to connect with who has a special interest, or maybe a skill set that would complement your interest. Next slide. So Kristen, do you want to talk about funding?
Sure. So like Adam just mentioned, in the agenda, we have a lot of information that I think is good takeaways. We didn't want to put it all in the slides, all the projects in the slides, but you'll find both the projects and potential research funding sources in a big table in that agenda if you haven't already seen it. But what we know is there's a lot of research funding available, whether it's through admin supplements or competitive revisions. 26 institutes at NIH are offering COVID-related funding, including OBSSR, the Office of Behavioral Sciences Research, NSF, the Office of Science and Technology. USC is also offering a few funding sources. If you haven't seen yet on the USC COVID website, there's a Zumberg Innovation Fund. That one's due on 5/11, so it's right around the corner. And like Adam mentioned earlier, Keck School of Medicine might have an RFA coming out for COVID-related research. There's a few private funding foundations listed in the agenda as well, one being Russell Sage. And that one looks at biopsychosocial issues coming from COVID-19. So I think that one particularly makes a lot of sense for everyone in this group. We also compiled some research and data resources for you. It's in Appendix D, but there's a lot of available data sets that you could use. There's research measures, surveys, and domains. Adam actually did a video on how to kind of change the way we think about doing lab research. It's on our YouTube page, but a lot has changed in the way that we can interact with our employees, do our research, and try to make what's happening right now a new normal that's productive, but also adaptable. So now we're going to go to our presentations. We have 3 to 5 minutes per presenter, and I will manage your slides unless you want to control my screen. Again, the Q&A function is available, or ask questions via chat. We're actually going to start with Dr. Dunton.
Great. Thanks to Adam and Jennifer and Kristen for that useful and helpful introduction. And it's great to have so many people here on this call. So I'm going to jump right in. I'm Genevieve Dunton. I'm a professor of preventive medicine and psychology, and I direct the USC Real-Time Eating Activity and Children's Health Lab. And our lab essentially uses real-time data capture and mobile technologies to understand physical activity, eating, and obesity risk in children and families. We also do work in young adults. And next slide. So we've recently, just about 2 weeks ago, launched a study that's looking at the effects of COVID-19 on physical activity and mental health in U.S. adults. And this was a quick launch, and putting all the resources and materials together, as rapidly as possible. And we're thankful for the IRB and their ability to approve this study within a few days, which was really a wonderful thing. And so we launched this study, and we're interested in understanding the effects of the pandemic. And you can see our theoretical model there in the upper right-hand corner. But what we're really interested in is understanding how some of the both voluntary and mandatory social distancing and quarantine measures that are in place, or that people are practicing, influence their mental health and physical activity. And probably these are things that we've experienced to ourselves and anecdotally, and we've been observing in the community broadly. But there's obviously, with restrictions in travel and access to gyms and other facilities, limited access to parks and trails, people's ability to engage in physical activity certainly has changed over the past month here, and we're really interested in trying to understand that, and even more so how these changes in their physical activity patterns are related to their mental health and may continue in the future. So I think one of the biggest questions is whether these initial changes we see in people's physical activity are going to persist, or will new habits form, either good or bad. And so what's going to happen in terms of long-term physical activity trajectories. And obviously physical activity we're very interested in because it's tied very closely to reduced risks of a number of chronic diseases, including diabetes and cancer and heart disease. So what we've been doing, you can see our aims here, and they essentially overlap our conceptual model, but we're really interested in understanding both these long-term effects and the daily within subject types of effects of these lifestyle changes on mental health and physical activity. So in the middle right panel, you can see our study design, and we are recruiting remotely through a number of sources, social media, and we've been advertising and communicating on various listservs. And we are recruiting a sample that is a convenient sample at this point, and given the limited resources that we have. But there's a baseline, and then we have 28-day EMA, or an ecological momentary assessment protocol, twice a day, and then in 6 to 12 months we're doing a follow-up survey. And we're really interested in trying to understand how these behaviors are changing across that long term, and as well as looking at day-to-day effects of mental health and physical activity and their covariance. So we have some preliminary data that are right here at the bottom. We have so far 382 enrolled in the study, and we did some quick descriptives here. And what we see here in this table at the bottom, we've been looking at change in physical activity levels. We asked people retrospectively about their activity in February 2020, and then we asked about the past 7 days when they completed the survey from April 10th to April 20th, 2020. And you can see that We do see some declines as we would hypothesize in vigorous physical activity, moderate intensity, and the number of days per week that people are walking. And certainly this is a concern. We start to see these patterns emerging, and we're going to be really interested in seeing whether this persists as the pandemic continues on, or are people able to adjust and find new ways to maintain their activity. So just to conclude, we have, in terms of our next steps, we're pooling data. We have collaborators in University of Colorado State and in Barcelona that are collecting similar data. We're trying to publish these results quickly in order to communicate what the immediate impact is, and then obviously we're going to look for the long-term impact. We're thinking about working with others and want to build collaborations within this group to use these data as some preliminary support for NIH administrative supplements or R01s, potentially on a larger cohort. And we really want to, I want to communicate that we can share our EMA and mobile health methods and expertise with any other collaborators on this call. And we've been doing this work with real-time data collection through smartphone apps for many, many years. And so if that's a method or a technology that you need assistance with, we're happy to help. So I'm going to conclude here.
Thank you, Dr. Dunton. Now we'll go to Dr. De La Haye.
Thank you. Thanks for having me. My name is Kayla De La Haye. I'm an assistant professor of preventive medicine at Keck, and I also direct the USC Applied Center for Applied Network Analysis. And so I'll jump right into my slides if you can go to the next one. We've been doing some work over the past year looking at food systems in LA, and when COVID hit, we started hearing from our community partners and the media the massive impact this is having on issues of food justice, food security, and sort of different stories about how this might be impacting the broader population's diet. And through a lot of unintended consequences of social distancing and stay-at-home policies, but also through the closure of schools and businesses and community spaces. So this is going to exacerbate an already massive problem in the US. In 2018, 1 in 10 households were already food insecure at some point during the year. We've seen 26 million people file for unemployment since COVID hit in the US. And so we are expecting this issue of food justice and food insecurity to really be exacerbated potentially over the next year or longer. We care about this issue for a number of reasons, many of them around issues of injustice and inequities, and also because poor diets and the inability to eat well has already been attributed to 40,000 deaths a month in the US. And so we are expecting this number to go up as these issues are exacerbated. So one of the needs that we've really focused on is trying to bring together an interdisciplinary team to understand how the LA food system, meaning the food outlets, the resources like pantries and food banks, and food environments, the spaces in which people acquire and consume food, how is this system responding to the pandemic in LA? And then secondly, to try and quickly assess the impact on the LA population's food access, shifts in food insecurity, changes in their diet, and ultimately sort of immediate and long-term changes that could happen in their health because of this, and particularly how these issues are impacting low-income and under-resourced communities and the elderly. So the team that we're working with, this is sort of my dream team of folks, and we're always keen to partner with other people that might be working in the space or interested in playing some role in this project. So we have a group of people from behavioral and social sciences that includes Mondi Bruin and Ari Captain, who will speak next, both from the Center for Economic and Social Research at USC, as well as Donna Spreitmetz from that group. Lourdes Baez-Conde from our department is also involved and a key person linking us to our community partners. And then we have this really great team of spatial and data sciences folks, including John Wilson, who's on the call, and Amelia Ferrara at ISI, and collaborators at MIT. And then critically, community partners that we have a history of working with, and LA Food Policy Council, who's sort of a backbone organization in LA for food justice issues, has been involved in this project. So next slide. What we are working on is pretty massive in scope and building on some of our existing work. We're trying to develop this pipeline of information and partnerships that will give us this rich perspective of the food system and how it is changing during COVID. And so one resource we've been trying to utilize is the Understanding America study that Ari will be speaking about on the next slide. So I won't go into that in too much detail other than from our perspective, this is a really amazing way that we might be able to measure change in food behaviors and food access from a representative and large sample in LA County that's already established. There's already an internet panel, and they have a wealth of data on these folks already, and they will continue to collect impacts on them moving forward. So we've been submitting for funding to add survey questions to that panel to assess those particular outcomes. We also have a team working with our partnerships with ISI and MIT to gather information that's available on the web and on social media and through people's cell phones that give us insights into real-time changes in what people are talking about in relation to food, what are some of the underlying social networks. We can gain insights into changes in the food environment through places opening and closing on Yelp and information on Google Places about where people are going. And then the other two pipelines that we're starting to develop is looking at ways we can capture data on consumers and the public through things like retail scanner data that already exists and trying to purchase that. And working with our community partners is a really critical piece in this project because in some of the other data sources, there's a lot of hidden stories that we're missing. Our community partners are talking to us about these massive lineups of people they're getting to try and access food that they get 4 times the calls that they typically do in a day, a lot from elderly people who are asking about food deliveries, and things like bodegas and corner stores really being vulnerable to closing during this time. And that's happening in neighborhoods where those places are really a critical resource for people that may not have a lot of transportation options to access food. So next slide. I will just mention briefly, like we've started analyzing some of the online data that we're getting, and we can see really quick changes in what people are talking about and where they're posting in food outlets. But I'll just jump to the last slide since I'm close to out of time. One more ahead, actually. So what we're hoping to do with this project is to monitor some of these real-time changes in the food environments because of the pandemic, really identify places in LA that have limited access to healthy food or limited access to resources like pantries and distribution systems. And then secondly, identify who is most in need of immediate interventions that are targeting their food access and hunger. And so we hope to quickly inform food interventions and policies. This is likely to be a massive problem over the next year and more. And also to gain bigger insights about this food system and food justice issues that might provide us with an opportunity to strengthen this system and improve inequities moving forward. So that is it from our team. I would be really happy to hear from anyone that's interested in partnering or that's working in this space. So thanks for giving me a few minutes. Thanks.
Of course. Thank you, Dr. De La Haye. And we will move to Dr. Ari Kaptein.
Thank you. And my compliment for pronouncing my name correctly, which is always a challenge for anyone I know.
I heard her pronounce it, so I'll give her the credit.
I'm impressed. So yeah, I'm going to talk about the Understanding America study, as Kayla already announced. So let's see if I can advance this myself. Maybe you can do it, Kristen. Right, so this is really the main slide, and then I'll show you a couple of pictures. So we run the Understanding America study, which is an internet panel of about 8,500 respondents. And they get interviewed regularly over the internet. And the distinguishing characteristic of it is that these people get recruited by address-based sampling. That means we send them letters and we invite them to become part of the study. And if they don't have internet, we give it to them. So we give them a computer, tablet, and we give them free broadband internet access. As a result, since we interview these people often, we have a lot of background data, as Kayla also indicated, and that's really handy if you want to do new analysis or if you want to analyze new data. So since March 10, we are doing a tracking survey, and we ask people about a lot of stuff, and I've listed some of this. After Genevieve's intro, I want to highlight the mental health and healthcare and physical health part. And actually we got NSF rapid grant to expand that. So the waves that's going in the field next Wednesday will have a lot more mental health in it. And also we have now added some food insecurity questions. Next slide. So the way this works, I'll explain the graph in a second. So the way this works is that every day, 1/14 of the samples, about 500 respondents, are asked to answer a number of questions in our survey. So once every 14 days, a respondent gets a survey about all the topics I mentioned and a few more. So what we have then is a daily tracking with a 14-day rotation. And then every 14 days, we also then look whether we want to change the content of the survey. We add questions, for example, the mental health questions I just mentioned. After a survey is out of the field, we make the microdata available for any researcher who wants to use them. And then moreover, we summarize the 7-day averages of what people say in a bunch of graphs. And you see one graph here, but there's a total of close to 2,000 graphs that people can look at. And you see if you look at the graph, you see Los Angeles County, you see national samples. You can either look at the national sample or LA. So I'm just going to show you two graphs. This is the one for LA, and it's just the number of people who have a job. And maybe a little difficult to see, but essentially in March, roughly 63% or so of people in LA said they had a job. And if you go to April, it's about 44. So that's a 19 percentage points difference. That means as a percent of people who had a job, about 30% of the people who had a job no longer have a job. So that's an enormous unemployment rate that implies. Let's go to the next slide. So here we have the same graph for the country as a whole. And here you see that the fall is sort of more abrupt, but actually the total impact is less, because there, let's say we have also about 63 or so in the beginning, and then it goes to maybe 50. And that actually implies a fall in employment by about 20%. And if you add to that the unemployment rate that already existed, you get to about 25% unemployment, which is still quite a bit higher than what the current official numbers tell you. And that's partly because not everyone is eligible for benefits. So those people don't apply for benefits. And also, not everyone has gotten it yet. So I think that's another part that isn't really quite clear yet, because the systems are overwhelmed. So it takes a while before all this shows up in the data. So these are just two examples. As I said, we have many more graphs, but the main thing is really the micro data that we make available, and we keep adding new stuff, new content to the panel. At this point, the funding is partly from our own resources and partly from the Gates Foundation, but we're sort of getting to the end of the funding. So, but we really hope to keep doing this at least until the end of the year, because we just know that this is only the beginning. This is going to go on for quite a while, and we keep adding content and trying out new things of interest. Thanks.
Thank you. It's really interesting. Dr. Lawler. We will. Maybe she's having a little bit of technical difficulties. So we'll go to Dr. Nguyen.
Win.
Nice to meet you.
Thank you. Hi, everyone.
Thank
Thanks for everyone who did the hard work of putting this together really quickly. I was really impressed with how fast you were able to do this. So I'm Dr. Annie Nguyen. I'm an assistant professor in the Department of Family Medicine. And next slide, please. So I just have one slide, and I'll briefly tell you about this project that is happening right now. So I work in the area of HIV and aging, and that sort of intersection between those two topics, and have longstanding existing community partnerships with folks out in Palm Springs who work in this area. And so with COVID happening, it sort of gave us a opportunity to lean on those partnerships and get something going really fast to be responsive to the current situation. And so what we're interested in looking at is the impact of this COVID pandemic with all the different shutdowns, the physical distancing measures, and how that's has had an impact on the day-to-day lives of older adults with HIV. And older adults with HIV, so you have multiple vulnerabilities with older age and with immunocompromised people. And so this project is happening out in Palm Springs. Palm Springs has a very large community of older adults with HIV. And what we are doing is we are putting together a survey. It's a cross-sectional survey that looks at the impact of all of this on basic needs, medical care, access to medical care, medications, mental health, and social isolation, among some other things. And we're pulling from the measures from the Pandemic Stress Index. We are pulling some of the same measures that are being asked right now in the MaxWise combined cohort study, which is a large national data set, longitudinal cohort on older adults with HIV. And we're also pulling some measures on a study called ROA, the research on older adults with HIV. So we can have some, we have sort of a localized sample, and we want to be able to compare to a larger national sample. So the strategy is that we are going to recruit through existing listservs that we have access to, that we know reaches a large population of older adults with HIV. We're collecting the data completely electronically. And where we are right now is we do have IRB approval to move this ahead. So it's amazing. Like in the last 4 days, this survey has gone through 10 iterations or something, right? Because it's happening so fast. And we've had a ton of collaborators look at it and give input. It's been reviewed by a community advisory board and its members. So right now we are in the phase of pilot testing the survey with a couple of CAB members, just to try out that process and make sure nothing's glitchy. And then we're looking to roll out next week and start to collect data, and looking to recruit 300 participants. So that's where we are in the study, and we hope, sort of on beyond sort of the research and scientific level, our community partners have very strong partnerships with local service providers, and we're hoping that this provides some real-time information to them so that they can think about how to adjust their services in order to meet the needs of older adults with HIV. So that's all I have, and I'm happy to speak with people who are interested in this area, who work in HIV and aging, and might want to collaborate in some way.
Awesome. Thank you so much. Dr. Polfus. Dr. Lawler, it looks like you might be able to go. Let me, I got your message. I'll get you set up, Dr. Lawler, to go. But we'll move on to Dr. Saxby, who looks like she's ready right now.
Sure.
Thank you.
Yeah, thank you so much for organizing this, and thank you for having me. I'm excited to talk about this project. You can go to the next slide and advance to the bullets. We know that stress and social support during the prenatal period are important predictors of both infant developmental outcomes, as well as maternal, physical, and psychological health, postpartum depression risk, for example. And so my lab at USC studies the transition to parenthood. We follow couples who are expecting their first child from mid-pregnancy across the first year postpartum. We look at hormones and neuroimaging, which we're obviously not doing since we've shut down our in-person data collection. But my students and I have been thinking a lot about stress, anxiety, access to prenatal care, even labor and birth planning, whether or not a support person can be present at delivery. All of this is really upended by the pandemic. So we very quickly, a couple weeks ago, converted the questionnaire battery that we're using for our in-lab prenatal visits into an online survey, which we're calling CHIRP, and incorporated measures of coronavirus worries, social distancing, have you had reduced prenatal care appointments, pregnancy-specific anxiety. And so we just launched this, thanks to the quick review from the IRB just about a couple weeks ago, and we already have, as of today, 630 responses from currently pregnant women and from some partners. So we've made the survey open both to women and also to their partners who are expecting parents as well. So you can go to the next slide. So just kind of getting into the data, we have already started to see some really striking and significant differences. So, we have the luxury of pre-pandemic data that we've collected prenatally from our existing USC Hatch sample, that's our in-lab data, and then this new CHIRP survey data that we've collected just in the last couple weeks. Demographically, our online sample is actually much more affluent and much more white than our in-lab sample, but we're still seeing significantly higher ratings of prenatal depression, anxiety, both pregnancy-specific anxiety and state anxiety, perceived stress, and we're also seeing lower ratings of social support and also antenatal attachment to the infant. So this is really concerning, and I think suggests that this pandemic is having a really, visible impact on prenatal health. And I think it'll be really important to follow this cohort through birth and then into the postpartum period to really look at what some of the outcomes are that are tied to stress exposure during this time. I mean, we know from even World War II studies that there's prenatal programming that can happen when there's really elevated levels of stress. And so this is a really unusual natural experiment that we're looking at right now. And we may, even with a large enough N, have the ability to look at trimester-specific effects, right? So stress when the pandemic hits during the first versus the third trimester. So the goal is to get some funding. So ideas welcome, collaborations welcome. Unfortunately, NICHD is not one of the NIH institutes that is getting COVID-specific funding. So that's really unfortunate because they would be the logical institute to fund this work. Because we really want to be able to pay the participants. So we've collected over 600 survey participants just by offering a raffle for a gift card. But we really want to pay them to be able to collect the follow-up data. We also, through DocuSign, have been getting HIPAA permission to access birth charts. So only about 1/10 of the sample so far has consented. They have to click through a couple of links after they do the survey. But we want to go back to them and get the medical charts of the birth so we can look at gestational age and birth weight and some of the other sort of medical outcomes that might be shaped by prenatal stress. So we really want to follow the sample. We need funding to do that. And then the other big goal that we have right now, our participants are about 83% white. And I'd really like to reach a more representative sample. As I mentioned, our in-lab participants are majority non-white. So if we want to be able to compare the data, so if people have ideas about how to reach a currently pregnant population or want to collaborate on recruitment, I'd love to talk about that. So please reach out to me. And then I also just really quickly want to mention, I'm also directing USC's new Center for the Changing Family. And we do have a small grants program for projects related to COVID-19 and the family. So please feel free to reach out with questions about that. We're collecting submissions for that program right now, and we'll be reviewing them over the next week or so. So thanks for having me.
Awesome. Thank you, Dr. Saxby. I'm going to move back to Dr. Lawler. It's all yours, Dr. Lawler.
Thank you, and thank you for the opportunity. What I wanted to do today was talk a little bit about some of our past and current projects, particularly relating to, you can progress to the next slide, particularly relating to look at the intersection of illness and disability in family life. We've done a interdisciplinary, longitudinal, primarily ethnographic or narrative phenomenological studies that have focused on the constitution of family life and the ways that families support both the developmental agendas and community engagement of their family members. We've been particularly interested in underserved populations, and much of our work has been with African American children with special health care needs, including autism, as well as their families, as well as the clinicians who serve them. In terms of family life, we've been thinking a lot about how so many families are organized around multiple illness trajectories, and how so often the way the clinical world is set up is to address sort of a family member who may have a particular developmental challenge or illness. But within the worlds of family life, a lot of times people are managing multiple challenges and multiple illness trajectories at the same time. We've also been very interested in the ways that families cultivate and develop expertise to meet the needs of their family members, and the ways that for many families, both strengths and vulnerabilities are so commingled that they're kind of best understood conceptually as being co-related. Our conceptual frameworks have drawn a lot on occupational science, which is where I'm housed in the discipline I'm in, which has a focus on thinking about the meaning of engagements and purposeful activities and how those activities can serve to promote health, as well as looking at the social worlds and the social contexts that afford and constrain people's participation, as well as influence their perspective on productivity and quality of life. In terms of our prior work thinking about disability, we've also been very interested in the interplay of ordinary activities and extraordinary activities in daily life. And for many families who we've come to know, particularly if they're managing either critical medical needs or challenging developmental needs, that achieving ordinariness in daily life is actually a kind of extraordinary achievement. So from an occupational science perspective, we're interested in how those sort of nitty-gritty of daily life gets orchestrated and supported within a complex family unit, such as a family. Our other conceptual frames include a lot of work in narrative and narrative theory, and it's part of my interest in thinking about how, with the pandemic, we can rethink about the ways that we're trying to understand disability, both in family context, but also in community life. As you know, narrative is a particularly useful tool for sense making. And as many people discuss it, we draw on narrative strategies very strongly when there's been a breach for the expected. And I think that's one thing that the world's experiencing now is sort of all these breaches in our sense of what was expected and what we've come to know, and how we then move forward in both time and in our lives to think of other ways of orchestrating our lives. And we're also interested in how narrative is used to structure action. It's not just a sort of vehicle for telling and representing stories, but it also is how people do things and work things together. And those of you from a more anthropological side probably know the expression experience near. Many people have argued that narrative gets us closest to experience of many of the ways of sort of social inquiry. So we're particularly interested in in that. In terms of thinking of COVID, we've got a lot of reasons to sort of recognize that it's a particularly trying time for families who are dealing with illness challenges and disability. Some of it's just the occupational disruptions based on, as many of you have talked about, changes in employment status, changes in sort of work life and how that's ending up reconfiguring family life and the stress that's gone along with that. We're interested in social connectedness on our autism project. We had a social network analysis component, and we're interested in sort of continuing combining that with narrative strategies. We know for many families, they're in situations where their caregiving needs have increased exponentially, but at the same time, many people have decreasing resources within their homes to deal with caregiving challenges. We also are interested in looking at sort of the bridging home, clinical, and community worlds. Much of our work has been thinking about how with managing illness and disability, all the work that individuals and families do to bridge their home life, their clinical worlds, and their community worlds. You can advance to the next slide. A lot of our work is multi-perspectival. We try to get perspectives of a lot of people, not to see who's right, but to sort of have the anthropological problem of trying to figure out how could it be that these are the perspectives of the people engaged in this. We've also very interested in emic perspectives, meaning the perspectives of people who are living with the phenomena. Our prior collaborations have been with medical, cultural, and linguistic anthropologists, as well as I mentioned, social network analysis. We've done a lot of work with clinicians and also with engineering on a project with medically fragile children who would be managing in the home. In terms of scope, we're recognizing that some of the work we've done has particular applicability at the moment in terms of particularly thinking about family life and thinking about the ways that people are managing the massive disruptive changes that have happened in a very short period of time. We're currently working on a project that's related to adolescents with autism and young adults in terms of grant applications, but we're open to sort of thinking of other opportunities and other ways of engaging with other collaborators, both from our prior work and our occupational science perspective. We're very concerned about some of the social inequities that are sort of compounding the health inequities, and thinking about ways that this pandemic is both revealing those, but demonstrating the need to have more impact on those. So you can progress to the next slide. This is, I know I'm running out of time, it's just a conceptual model of our narrative and phenomenological approach. And I can end there. These next slides show some of the past and funding and current project. But thank you for the opportunity. Please let me know if those of you particularly that are interested in family life, if there's ways you want to engage. Thank you.
Thank you, Dr. Lawler. And we'll move on to Dr. Polfus. Thanks for joining us.
Hi, so I'm in the Center for Genetic Epidemiology, and I'll be discussing the multi-ethnic cohort. This is a prospective cohort that began in the early 90s, and it's in 5 ethnic groups in Los Angeles and Hawaii. Next slide, please. So there was a recent article that came out 2 days ago in JAMA that was on 5,700 COVID patients from the Long Island, New York City area. And they found that 56% had hypertension, 41% were obese, and 33% were diabetic, which raises the question, is COVID having worse outcomes in people with comorbid conditions? And then in particular, since the normal prevalence of diabetes is about 9%, this was kind of alarming that it was 33% in COVID patients. So the multi-ethnic cohort has right now about 40,000 individuals also with genetic data, and this is imputed to multiple platforms. So we have up to 30 million variants. So another thing the JAMA article mentioned was that they looked at medication use patterns, and that's of the angiotensin converting enzyme inhibitor and the blocker. And they had medication information on about 10% of the patients. Or they had the information, and then I think it was on the subset of the 5,700, and then they found 10% were using one of these medications. And then let's see what else. So right now, there is a recent mailing that is about to go out to Los Angeles and Hawaii participants to ask about their COVID status. So, and I've also recently worked on a type 2 diabetes genetics paper. And here's the list of numbers on the groups by ethnic group. The European Americans were from Women's Health Initiative and the Diagram Consortium. So another resource we have available is the Medicare Part D linkage. So this would be participants over the age of 65 that are part of Medicare and also linked to multi-ethnic cohort, and then who have genetic data, or with or without genetic data depending on the question. And we can look at the angiotensin converting enzyme kind of question, because there is a question about whether people on these medications have more expression of the ACE2 receptor. And as everyone knows, that's what the virus connects with the spike protein to the ACE2 receptor and then allows to enter into cells and replicate. So we're wondering how that plays a role. So another role I have been in is under this manuscript that's under review in diabetes care, and that's part of the PAGE consortia, and that's on a much larger group of individuals, and it has a polygenic risk score for 5 ethnic groups. So I could envision like seeing if those in the extreme of diabetes PRS are more likely, to have severe COVID or some kind of question like that. So at this point, I mean, it's easy to pull from this analysis that's already been run the variants in genes of interest that are related to COVID, such as ACE2 and TMPRSS2. And that's kind of where I'm going to stop. Something else I have similar data on is COPD, but I'm kind of waiting to see what the literature says because it's changing daily. That's all I have.
Thank you very much.
Thank you.
You bet. Just review Dr. Saxby's really quick and we'll move on to Dr. Trost.
Hello. Hi, I'm Margaret Trost. I am a hospitalist and pediatrician at Children's Hospital Los Angeles and an assistant professor at Keck. And I am going to talk about social robotics today. And you can go to the next slide. So I apologize, I didn't put any cute pictures of my robots on this slide because I put it together kind of quickly. But what are social robots? So robotics are used in a lot of different ways in medicine. Certainly you may have heard of surgical robots, which are smart machines that can help in surgery. There are rehabilitation robots, which can be strapped to people to help them gain increased functionality after traumatic events. Social robots or socially assistive robots are robots that are designed to be pleasing. So they are designed to be companions to people. They are designed using different kinds of techniques to make them look like something that people would want to interact with. And they interact with people via verbal communication, so they can talk, or they make movements, but they don't usually touch the other the patient or the person that they're interacting with. And the goal is really that through the interaction with the robot, some kind of behavioral or emotional change is affected in the person. There is a large center for socially assistive robots at Viterbi with Dr. Maya Matarik, who many of you I'm sure know. And I have worked with her and various different robots that she has available in her lab to try to affect change in hospitalized children, since as a hospitalist, I work only in a hospital and I don't work in a clinic. In the hospital, the major problems that we see with children that we've tried to use robotics to help are fear and distress associated with the act of being hospitalized. So kids obviously get scared when they're in the hospital, and they are subjected to a lot of different procedures. And for those of you who may have not been in a hospital much, a lot of times their parents are not around. Parents have to leave and go do other things. They have other children. And so sometimes the children may be alone in a hospital setting, which can be additionally stressful. So what we are thinking about even more now in this time of COVID is all of the things that go on to help a child in the hospital be less scared and have less pain usually involve other people. We have things like child life specialists. We have our dog therapy program where dogs come into the rooms to cheer children up. All of that has been canceled in the time of pandemics. And so in order to try to show how we might help that situation, one of the possible interventions is these socially assisted robots. So like I said, we've used them before. We're trying to just use them again in a similar situation, but sort of with more emphasis on how this can help in a pandemic, because robots obviously don't need to wear PPE when they go into a room. They don't have to wear protective equipment, so we can have them go in. And there are types of robots that can operate independently without an operator involved, so we can send them in to talk to the children, help calm them down without needing to have extra people be in the room. I have a medical student who's very interested in this project who works in the burn unit at Keck. And we also have another potential patient population in the patients that I work with at Children's Hospital Los Angeles. And one of the things that I'm really looking for is increased behavioral health and psychology partners to help really make sure that we're designing a good interaction between our robots and children. I've worked with Jeff Gold at CHLA, who's a wonderful psychologist. But additional people who may have expertise in fear, pain, or distress may know more than I do about the best ways in which to measure those emotional outcomes, and so that we can incorporate those things into the script and the interaction between the robot and child as we try to roll out some of these projects. And short presentation, but that's all I really had to say. So I'd be happy to have people contact me offline or ask any questions in the chat.
Thanks so much. All righty, well, moving on to Dr. Unger and Dr. Barrington-Trimis.
Hi, everyone. Thanks for joining. It's pretty exciting to see so many people here. Just checking in with Jen to make sure she's on.
I'm here. Yeah, but go ahead.
Okay, great. So I'll talk just a little bit about the resources, primarily resources that we have available right now. So between me and Jen and Adam and a couple of other PIs, we have 4 current ongoing cohorts of youth and young adults in the Southern California area. All of these cohorts have been or will be collected from schools, so they are relatively population-based and you know, roughly representative of the population. We began data collection for the primary data collection began around 2013, although there are some caveats there. And we have data collection that is currently ongoing and planned through 2024, potentially with the goal of extending this beyond that as well. We have data ranging from age 14 to 24 right now, and again, like pending future grants that may expand. The total N across all of the 4 cohorts is between 8 and 10,000, depending on kind of what waves of data and what cohorts and so on and so forth. I will talk about each of the 4 cohorts and sort of where they are right now in terms of their age and how they kind of compare to one another in just a second on the next slide. Briefly, actually, can you go back, Kristen? Sorry. We have a lot of, all 4 of these cohorts were geared at really understanding substance use. And so the majority of measures, we have a lot of measures on substance use, but we also have measures on mental health, on demographic characteristics, of course, on peer use, on behavioral risk factors, advertising, and we are right now adding questions on COVID-19 to the cohort studies. And we've developed a solid set of questions related to both whether people actually have had COVID and whether, like, how they're just dealing with the pandemic in terms of different things that they may be struggling with throughout this time. Okay, so this is like a very big picture overview of all of the cohorts that we have. So I know it's really hard to see and really, you know, you can't look at probably can't read the numbers right now, but I just wanted to give kind of a big picture overview of like all of the data that we have at present, including existing data and new data collection. So on the left-hand side in white, these are the data that we currently have available, totally collected, ready to go. 9 waves of the H&H data, 4 waves of the CHS data. The CHS data ranges from age 17 to 21 or 22, and H&H from 14 to about 19 right now. And then the right-hand side of this is all of the planned data collection. So this is data collection that is funded, supported, that we're planning to collect across the 4 different cohorts. And actually, let's go to the next slide because we have a bigger version of this. Okay, so this is existing data that we have. So I'll just very briefly go through the 4 different cohort studies. So the CHS, we initially started collecting data related to tobacco use in spring of 2014 when they were in 11th or 12th grade. And we have continued to follow them roughly every year through present. At spring 2020, we are about 3/4 of the way through the current data collection. That cohort started out about 2,100. We've had relatively good retention after high school. And about roughly, I think we have about 1,100 surveys that are collected now, but for the new data collection that began in February of 2020. For H&H, we surveyed them every 6 months when they were in high school from fall 2013 to spring 2017. The cohort started out about 3,400. We had about 95% retention across the cohort. So we have about 3,200 kids that had data through high school. And again, a lot of surveys on mental health, on substance use, and so on. We finished the first wave of data collection post-high school with about 80% retention. And we are just about ready to start the next wave of data collection, which is going to happen sometime in the next few weeks. The next cohort is a new cohort called Titus. We began recruiting them in fall of this past year, 9th graders, with the plan to collect data every year through high school. And so we have about 1,700 or so participants who have completed data collection. So, and Kristen, you can go ahead and go to the next slide. Yeah, so this is just like a quick snapshot of all the future data collection that we have. Mostly just to say we have a lot of opportunities for collaboration. We have a lot of data, and you know, we're very open to collaboration. And can you go to the last slide, Kristen? Yes, so this is just a call to collaboration. We are very open to people using our data to write grants, to write papers, student projects. You know, we're very collaborative. We have a lot of people collaborating on this project and a lot of data collectively. So yeah, so get in touch, let us know. We're very excited about collaborating with others.
Thank you. That was awesome. So let's see here. We have a Adam, are you on? Would you like to present, or should we move to the panel?
No, maybe next time.
Okay.
But I want to make sure that there's like enough time for a discussion. So Kristen, what's the format for the this panel discussion?
So we have one question that was sent via the Q&A function. Let me pull that up really quick. Dr. Whipfley said, Ari, does the study collect alcohol consumption data? So Dr. Captain, if you can respond to that.
Sure. Yes, so the answer is yes. And I should add, as I said earlier, we can always add other items, but at this point we ask a number of questions about use of alcohol and various kinds of drugs, and a number of questions about mental health, loneliness, stress, depression, etc.
Great.
Ari, can I follow up? The design it's like a panel cross-section, right? And so there are different groups of people, or are people resurveyed as part of the study design?
It's a pure panel. So everyone starts again every 2 weeks. So what I showed were just graphs of averages. But for example, if you want to look at changes, you can look at the same people over time.
Okay. Yeah.
So these are really the same people and we keep following them. Generally we follow them over time, but in this particular case, we keep following them every 2 weeks.
Great. Yeah. Well, I'd love to talk about doing a paper on substance use with you if you're open to that.
Okay. Thank you. I have another question here. And just a reminder, if you are an attendee, you can raise your hand and I'll unmute you and you can ask the panel a question. This question is for Dr. Lawler. How are you measuring social connectivity, and is this related to the construct of connectiveness used primarily in social studies?
Thanks for the question. It is related in terms of actually measuring social connectivity. On the autism project, we did a social network analysis with Tom Valenti. Using an egocentric model, a lot of our work actually starts with a case and then spreads from the case to see where they are connecting. And as I mentioned, we're in the process of looking at doing something similar with an adolescent and young adult population. From the more phenomenological side, I wouldn't say we're measuring social connectivity, but one of the benefits of narrative inquiry is it often gives you a sense of how people are perceiving and representing their connectedness to others. So we also have a lot of phenomenological data about how people are both relating their sense of connectedness with others and how it also relates to their actions and activity patterns and other kinds of things.
Thank you, Dr. Lawler. We have another question here. Are folks adding COVID-related questions to existing research projects? And if so, how are the investigators choosing which questions to ask and how to keep those questions succinct? I know there's a few resources out there. I don't know who wants to tackle that one from the panel.
Maybe I can say
Please.
something, because of course that's what we do, because the Understanding America study is an ongoing survey. The question about how we pick questions, just like everyone else, I guess, intuition, sort of look around, see what's going on. So we have a number of basic questions, but then we also respond to societal development. So for example, the number of questions about the economic effects and about food insecurity has gone up quite a bit, simply because these are now the pressing problems. Initially, we asked more questions about fear of the virus and people's perception of the chance of being addicted, of being infected and all that. So so partly we try to respond to what we think is most relevant at this moment.
Great, thank you. Does any other panelists want to mention something?
Yeah, I just wanted to, so NIH is really pushing two sources of measures, and I'm going to post them. One is the FENEX toolkit, and then there's the NIH Public Health Emergency and Disaster Response, the DR2. So I'll post those links. I've actually been looking at those, and I'm not, the most fond of some of the questions in there, but they're really pushing it. I keep getting, emails from NIH about using those. So I'm assuming they're going to continue to add to those toolkits. So, but I'll post the links.
Thank you, Dr. Dunton. Dr. Saxby, did you want to?
Sure, yeah, because we took an existing questionnaire battery that we've been giving to our pregnant couples and modified it for our online study. And we did look at some existing sort of OSF repositories of questions and questions that had already been used. We ended up just kind of writing our own. One thing we did is use some of the standardized measures that we've been giving and just adding a question, has your social support measure, and then has your social support or your social connectedness changed as a result of the pandemic, and just had people respond on a slider. But I'm really happy to share the questionnaires that we developed and any of the measures that we're using if people are interested.
Thank you.
Yeah. Yeah, I'll just chime in there as well. So we kind of did the same thing. We took a look at existing measures, and ultimately at the time when we started developing our questionnaire, there weren't really that many existing measures. So we did a lot of just development of our own questions regarding things that we felt were really important, and we adapted that a little bit to the NIH NOCI that NIDA sent out with the specific things that they were interested in with respect to substance use, and we added that to our questionnaires. And we are also very happy to share the COVID questions with everybody.
Great. If anyone has resources such as measures, email them to me and I'll create a Google Drive with all of this information that can be easily accessible by all the attendees as well. We have one question from Dr. Sugar. I have unmuted you, so the floor is yours.
I'm sure most of the people in this audience are familiar with the concept of childhood adversity, popularized through the ACE study, which is now about 30 years old. There's a lot of misunderstanding about what that study actually showed, and there's been quite a bit of work on refining the way people are asked about those things. But I don't think there's much question that personal history of trauma and adversity has powerful mediating effects on later health outcomes. And I'm just wondering if anyone's interested in, I've been working for about the last 6 years to refine a measure with a psychologist now at University of Connecticut who developed the traumatic experiences screening inventory for children. And we've been field testing it for, in our pediatric emergency department. I think I'm wondering who might be interested in looking at that as a possible, mediating variable.
Mm-hmm. Hi, Jeff. This is Jennifer Unger. I'm interested. I'm working with a colleague at Cal State Northridge who's about to launch a study of college students, and she's very interested in ACE. So we'd be happy to include your measure.
Thank you.
Yeah, ditto. We should talk more. I'm interested in adding that to the cohort studies as well.
Yeah, if we could put that on the T-course study, that would be great. I think that would be really helpful.
I can forward it to Kristen to upload.
Great, thank you.
Perfect, thanks.
Thank you. It looks like there's a few people interested in that, so thanks for bringing that up. Dr. Valdez, the floor is yours. I think he's trying to unmute himself.
Am I okay? Can you hear me now?
Yes, you are okay.
Okay, yeah, I wanted to chime in that I would also be interested in looking at that measure, since we're thinking of, we're also interested in traumatic experiences as impacting health with the population when we're working with. So I'd like to follow up and have a discussion on this issue. That's it.
Great, thank you. He's from the School of Social Work.
Yeah, I'm from School of Social Work, Roberto Valdez.
Thanks for being here. Any other questions we have?
So yeah, I can just raise something too. I don't know if everybody's still on the call, but regarding the multi-ethnic cohort, that cohort, they're over like 7 years old or 6 years old right now. Is that correct?
Yes.
Yeah. Okay. Thanks, Linda. There you are. And so, because we have some folks interested in gerontology too, but maybe would there be opportunities for people if they're interested in, in addition to genetic studies, but kind of other factors that have been looked at in the multi-ethnic cohort?
Yeah, they've captured quite a bit on diet, and then also some physical activity. Of course, cancer, all types of cancer. It's linked to SEER. I'm trying to think what else.
And I believe that like they were working on a project where they were trying to do some geospatial coding of like societal or disadvantage or deprivation. I'm not sure if you're aware of that too, but that might be of interest to some of our attendees.
So I believe those projects are led by Anna Wu and Iona Chung. So they have geospatial coding for predicted air pollution measures. And then also I think they were looking at tobacco use and by census tract, some kind of risk calculation for being near, tobacco dispensaries. I know Lonnie, before she went to University of Hawaii, had submitted a grant with Iona Chung on that topic.
Thank you. There's a question, I think, on the Q&A from Christine Naya about standardized questionnaires used to measure possible COVID exposure and anxieties and stress around COVID. So yeah, with the resources, like with the Dropbox, that'll probably be able to help a lot of folks. But I did actually find one published like psychometric study about kind of anxiety and fear related to COVID. So I was surprised to actually see something published so quickly. So that's something we can add to the Dropbox too. It's kind of an interesting measure.
That'd be great, thank you. Dr. Wilson, I've unmuted you so you can ask your question.
I was just going to make a comment. At USC, we have lots of geospatial people and lots of capability to produce resources. My colleagues and I work with many people across the university. So if you have any geospatial questions, you're welcome to contact me. This is John Wilson in Spatial Sciences in Dorset.
Thank you very much, Dr. Wilson. We have a couple more questions in the Q&A. One for Dr. Pulfus. Can you elaborate on the data sets? Well, you might have already answered that. You have to point to a resource, and two, a broader data availability question. What kind of mobility transport data sets are available to use since most of the data is not free? Sorry if you already.
Wait, okay, I already answered the first one, and then the second one is not for me.
Oh, it is for you too. What mobility or transport data sets are available to use?
Oh, I don't know that question, but I have heard mention from Loic at University of Hawaii, an app. So I don't know what they're collecting from that app, but that question could be directed to Le Marchand.
Awesome. Okay, thank you. We have another one from Dr. Furman. I was wondering if anyone is studying any of the positives that will occur because of COVID, from the environment to parents bonding with their children, to increase elderly more involved on computers. There are a lot of other positives, but is anyone studying any of the positives?
So I can speak to that a little bit, because with our prenatal cohort that we're planning to follow, one thing I'm really interested in is parental leave and ability of new parents to take time at home. And my guess is that, so we're asking people who are pregnant if their leave plans are changing because of this situation. I think we're going to see some real disparities in who's able to have more time at home, but it certainly may be the case that some of our new parents will be able to have more time at home, which might support breastfeeding initiation and some other outcomes in our infants. So that's one possibly good effect that could come out of this.
Can I also just comment too, and then other folks can comment if they wish as well. But so regarding the 10,000 youth and young adults that Jessica was presenting about, you know, we're really enthusiastic and interested in leveraging that cohort to address a lot of questions, right? And so we think that it's a really interesting cohort because we've been following people over time from different kind of age groups. So in historical cohorts, we'll have the class of 2024, the class of 2015. So kind of all these people who are going through probably the most turbulent time in your life, adolescence and young adulthood. And then so now they're they're stuck at home and they're probably finding some better ways to interact socially, either through digital media and maybe with their family, and vice versa. They're probably finding some unhealthier ways. So we're really kind of interested, I think, in looking broader, although, you know, like a lot of the interest is looking at the kind of the ultimate outcome of mental health and kind of health behavior. There's a lot of interest too in kind of the mechanisms, and we'd love to collaborate with developmental psychologists, social psychologists or social scientists, people who know a lot about kind of digital media communications and things like that. So, and then also, yeah, with John Wilson's group too, about taking kind of phenotyping the environment, right, and kind of leveraging that to understand a number of factors. So, yeah, I just kind of want to mention that we hope that you know, this and kind of the other resources that were presented here, that people do follow up and do want to kind of help us inform what we're going to assess, and then use the data that we have to address some interesting questions. There could even be some interesting modeling longitudinal questions about kind of how the shape of mental health, substance use, or other behaviors that we collect changes over time.
Thank you, Adam. We have Dr. Moran on the phone who would like to ask a question.
Hi, everyone. This is Carlos Moran with School of Social Work. And I have a question for those who are doing, who have questionnaires and studies going on. Are any of them assessing the impact of the disruptions that have occurred in the safety net systems? You know, things like social services, primary health, mental health, substance abuse, etc.
So we do some of it. We ask people about, for example, we ask about source of income. So we know whether or not they get benefits of various sorts. We know whether they have a job or not. We also know where they were before they lost their job. So we know something. We actually know quite a bit about the socioeconomic gradient of how this affects people. So it doesn't cover everything you're asking, but I think we cover a fair bit of that. And indeed, the holes in the safety net are probably the biggest concern if you look at the effects of COVID, and we try to measure this as well as we can. I should add, by the way, the data that we produce are really, you know, once it's out of the field, anyone can use them, right? So you just go to the website, you sign up, and you can use them. And on the other hand, we're always happy to add questions, although there's a little condition there, which is that it takes money to do that. But you know, we're definitely always open in trying to make the data more relevant.
Okay. Thank you.
Thank you. And if anyone else has an answer to that, you can feel free to share it in the chat or email me, and I can connect you with Dr. Moran from the School of Social Work. We have one last question before we wrap up. This one's for you again, Dr. Captain. What percentage of the sample are from racially underrepresented groups with UAS, and do you oversample these groups?
I don't know by heart. There, you know, but the sample composition is easy. If you look at the data, it's easy to find. We don't oversample underrepresented groups. We try hard to have a representative sample of the country. And if I sort of, off the top of my head, I would say we're doing reasonably well in general in representing the various groups. The biggest problem we have is that people with lower education tend to be underrepresented. But for example, since we have a pretty big LA sample, which we indicate separately in the data, for example, we certainly have, enough, if you like, Hispanics. I think blacks are maybe a little underrepresented. So it's a little off, but not all that much. I think in terms of ethnic composition, we're in pretty good shape. There was a question about Asians and discrimination of Asians. And we actually see this. There's very strong evidence that there is discrimination of Asians as a result of the virus. But still, the number of Asians in the population is relatively small. And as a result, it's also relatively small in the panel. But in any case, if you go to the website, you can easily sort of browse it and you'll see the composition.
Well, really good. Thank you everyone so much for special thanks to the speakers. Great questions. Thanks to all the attendees. So one of the things we didn't know was whether or not we'll have another meeting, but I think it seems like based on the interest, and there were other people who wanted to present, we will have it. And we will mark your calendars for Wednesday, May 20th, 11 to 12:30 p.m. Email Kristen, myself, or Jennifer, but Kristen probably has the answer. If there's particular resources or you want to know like, oh, who is that person who said this about that, and how do I contact them? Let us know, and then we'll follow up with a bunch of different types of materials, probably more than you need, that'll help you with getting funding and using resources, survey measures, etc. So we can kind of keep this going.
Yes, thank you all very much, and feel free to email me with ideas for this group or any particular needs, and then share resources, and I'll send you the slides, the agenda. It's a long agenda, so make sure you scroll down, and then any available resources that are sent to me. So looking forward to working with you in May. Thanks, everyone.
Thank you, everyone.
Thanks.
Thank you.
Thanks. Bye.